the chat facility also in the meantime. If you've got any questions, put them in there. Kelly will keep an eye on those, or if you've got a question, please use the buttons. I think it's the reaction button on my screen, and raise your hand, and hopefully at some point we will get to your questions.
Super, good. Just to explain, the format for today is our expert panel, Professor Ray and Debbie Kane. We've got pre-submitted questions, and a lot of you are here who have submitted the questions. So Kelly and Rupal are going to put those questions to the panel. They will then answer, and if you are at the meeting, we'll give you a chance to then comment upon the answer. As ever, time is the enemy, so we're going to have to jog along through as many questions as we can. And we're about halfway through the questions. We're going to have a quick break for the annual Dizzy Awards, which are actually harder to win than Oscars. So, and probably more deserving as well, I must say. So that will be halfway through, and then we're going back to finish the questions, and then at the end, sort of general questions from anyone, and that should be it. And we're aiming to finish around 2:30ish, but it may run on a little bit. So first of all, I'm going to ask the panel to introduce themselves, and then Rupal is going to start the proceedings with a first question to the panel. So if I could hand over, Debbie, if you could introduce yourself and explain to the members your knowledge, skills and wisdom, and over to you. Thank you. Oh, got to unmute.
No. Obviously my primary role is as a reindeer. But yeah, my name's Debbie. I've not got lots of letters after my name. So I'm a clinical scientist in audiology who's been testing and rehabilitating patients with chronic dizziness for many, many years. And I bring my own sort of model to this, a mindfulness, cognitive behavioral therapy approach to patients with persistent dizziness. And I also lecture at Manchester University. And I've got a floppy antler, which is quite upsetting. I'm sorry about
that. Thank you, Debbie. What about you, Peter? I think most people know Peter, but...
No, thank you. Well, I don't look as spectacular as Debbie, Kevin, or indeed anyone. It's lovely to see so many familiar faces. So hello to everyone who's tuned in. I've only got a Christmas tree, I'm afraid. Sorry, I haven't got a Christmas jumper on. So for those who don't know me, my name's Peter Ray. I'm ear, nose and throat surgeon based in Leicester. We've got a big clinical practice here, a Balance Centre in Leicester, where we handle about 7,000 dizzy appointments a year. But I've got a number of other hats, which I hope will help answer some of the questions. So I've managed to get a professorship at De Montfort University and Leicester University, our two big universities in Leicester. So there's a big research programme going on into lots of different areas of dizziness. I do a lot of teaching. We run a big balance course here each year for people who come from all over the world, and I travel all over the world teaching as well. And I have a political hat on, trying to represent you and doctors to try and make things better. So I was president of the British Society of Otology, which is our ear surgeons organisation, and then next year I'm president of the Royal Society of Medicine, part that does ears and dizziness. So there's lots of ways of promoting what you and I want for each other for balance, and that's sort of what my role in life is.
Brilliant, thank you, Peter. So before we start off with the questions from everybody, I've got a question about 2023. Let's start off on a positive note. Of course, we've had terrible times with COVID. And we're still trying to recover from that, and of course other economic issues as well. 2023, what will that bring in terms of levels of care and any new developments that might give us some positive news and help our balanced community? Debbie, let's start with you.
Yes, apologies, I've got a bit of a cough and a cold, so if I hack away, I'm not a 50-a-dayer, as my friend just mentioned as I was on a walk with her. I think there's so much to be positive for, and I do not like Zoom, but I think the brilliant thing which has come from Zoom is that people have connected via Zoom, via this amazing group. I've also got a mindfulness group because I'm a mindfulness teacher, and people connect there. And so I think people, if you've got persistent dizziness, you can feel very isolated, you don't know what's happening. And so connecting with like-minded people in a positive way is fantastic. As regards the future for care for 3PD, I think we've really raised the awareness over the last few years. And I think there's lots of really fascinating research going on about how 3PD, the chronic dizziness type, is caused and how we can best manage it. And so I think the future is bright, both with the ongoing research and also with everyone linking up and feeling heard and feeling understood, because I know that you guys, because it's a hidden disability, and you all look fantastic today, but that sometimes hides what you're feeling inside, and therefore people don't understand. So I think we should really continue to try and raise awareness so that people do better understand, and more of us are getting an understanding and wanting to support you guys to live well with whatever symptoms you've got.
Thank you, Debbie. Peter?
Yeah, that's a great positive message, Debbie. And I would say the same. And if we just look locally in Leicester, our balance unit, although we have a large number of patients coming through, is getting a bit drab, and it's going to get knocked down because it's going to be the new entrance to the hospital. But we've got plans all drawn up and costed for a new dedicated balance unit, probably at the General Hospital, with really fabulous facilities. We've got a fantastic staff there as well. So I think clinically, we're trying to expand our balance service here, trying to get our waiting times down, and we're having some success at that. The government's really pushing for hubs, care hubs, and I think that's a really positive thing in the NHS for the future, because of course a lot of our appointments are cancelled because of emergency care, pushing out elective care, and all of us here want elective care. So getting dedicated care in elective hubs outside of emergency hospitals is a really good thing. And we've been hugely successful getting our waiting times down for complex surgery. 18 months ago in my department, you'd be waiting 2 years for me to operate on you. If you had something eating into your skull, I can get you in almost straight away now. It's really fantastic, some of the progress we've made. Not so for some elective stuff. We're really struggling on some bits, but there are lots of positive things there. And as we've just heard, research, lots ongoing, lots of exciting things to talk about as well.
Brilliant, thank you. We're going to crack on there with the first question, and it's from John, who talks about living with bilateral vestibular loss for the last 3 years. He's been living with these symptoms for 24/7, unsteadiness, oscillopsia, cognitive problems, nausea, sensory overload in busy environments. He feels like he's reached a bit of a plateau, really, and all treatments have stopped. Does he now accept that this is his new normal?
So Peter, I thought I'd cover this one initially, if that's okay.
Of course.
Yeah. So how do I now accept this as my new normal? I think this new normal is a phrase which comes from a book that many of you may have read, Joey Remini's Rock Steady. Do I now accept this as my new normal? The only person who can answer that is yourself. There's this concept, this big concept of acceptance, which I could talk about for hours. So acceptance is kind of coming to terms with and living well with. And so whether or not your symptoms improve or not, I think that is quite a fundamental thing for people with our persistent dizziness. Having said that, it's incredibly hard to do. So just because you've reached a plateau, that might not mean you can't reach greater heights. But coming to terms with the fact that you've got these symptoms and fostering an attitude of living well with and despite, actually, ironically, sometimes helps you improve further. It's quite often what we resist persists. So the more we want to try and get rid of our symptoms, the more we focus on them. And from a psychological point of view, the more our brain gets worried about them and heightens them in our awareness. So it quite offers this term, the acceptance, the act of allowing the living well with, allows us to turn off that sort of negativity of the brain and to carry on. And it's a concept quite well known in chronic pain, actually. How you accept, now that is another big question, and that's more than we've got to have time for today. But I don't know if people saw Dr. Symptom's talk, I think last year, which contained some really good stuff about acceptance and living well with. And I've put together a little handout of some other resources. So there's another one by Vidyamala Birch. And so I think those, and it's rather like it's a grieving process. So I don't know if any of you have grieved for a loved one. You have to go through this cycle of loss. You've lost your balance organ function and all the changes of that, being angry, being depressed, and then eventually kind of coming to accept with it and living well with it. And that takes a long time. But if you can do that, probably you're more likely to improve further. And you can always ask for more help as well. Just because your therapies have been terminated at the moment doesn't mean to say that the future isn't bright and you can achieve great things. So keeping that attitude of positivity and, you know, getting on well, getting on with stuff despite, very difficult to do, but those are two things that you probably need the help of someone to help you through. That's the kind of work that I do with my patients, because I know it's really easy to say and very difficult to do. But at the end of the day, it's a question that only you can answer. And I wish you well.
Peter, any thoughts from you?
Yeah, that's a great answer. My initial answer would be it depends, because you're telling us that you've got bilateral vestibular loss, and it rather depends from a clinical perspective what is meant by loss. If you've got total bilateral vestibular failure, so for example, if you've had a serious head injury or you've had gentamicin therapy for infection, systemic gentamicin therapy, and you've lost all of your balance function, then yeah, that advice absolutely holds. Now, the fact that you describe oscillopsia, and for those of you not familiar with oscillopsia, this is when the world moves up and down as you walk. It's a bit like having an old camcorder and you're looking at the video, because the critical reflex of balance is the vestibular ocular reflex. So that's the reflex between your ear, vestibular, and ocular, and your eye. And what you don't realize is when you're walking, your eyes are doing this the whole time. They're moving up and down the whole time. So when you look at the horizon, it looks stable. And in our patients who lose balance function in both ears, that reflex doesn't work. And it's absolutely awful because the world bobs up and down, oscillopsia. It's a really distressing state to be in. The reason I said it depends is it depends whether you've lost all of your function. So some of our patients will come to us with bilateral vestibular hypofunction, so a reduction in function, but not total loss of function. And there may be some strategies we can use to improve that. If you've been through the whole range of therapies, that may not be the case. And the other bit of it depends is there is real interest in research in this area. And you may be familiar with cochlear implants, which are bionic ears, where we drill a pocket into the bone behind the ear and we thread an electrode into the cochlea, the inner ear hearing organ. And it's miraculous. People with profound hearing loss, children with profound hearing loss, can actually hear well enough to speak on the telephone somehow. Sometimes it's extraordinary. And what a lot of work is going into is to try and get vestibular implants. Now, in theory, we thought this would be easier than, we thought this would be easier than with a cochlear implant, but it's proving difficult. But there is a lot of money going into this, and who knows, let's hope in the future we'll be able to get implants that work.
That's just highlighted something in my mind. There's a number of things which are being developed which are less invasive or not invasive at all. And something that I've just come across quite recently is something called the balance belt, which seems to be having some really beneficial effects on people with bilateral loss of function, whether it's complete or reduced function. And this is essentially a belt that you put around you, which if you veer to the right, it vibrates in the right. And if you veer to the left, it vibrates to the left. So you're kind of using your sort of proprioceptive input, your joint input, to help you balance. And I don't know if you've come across it, Peter, actually, because it looks, you know, initially I was sort of quite skeptical, and they're researching it all the time, but it is looking on some people that it's having really some beneficial.
There's a number, yeah, that's a good point. There are a number of strategies like this that have been developed. Joel Goebbels over in St. Louis developed a cap which does the same. So it vibrates on one side depending on which side you go. And these are all good ideas. They haven't really taken off, but I mean, if you get someone to walk down the straight and narrow and turn their head, it definitely makes things better. But as a long-term fix, it hasn't quite worked yet. But you're absolutely right. There are also non-invasive techniques that have been looked at.
Thank you.
Oh, so Steve actually said he's used the belt. Steve, how did you find it? Would you like to share? maybe
There you
not.
go. Sorry, yeah, just trying to unmute myself. Yeah, I did. I was able to use that belt when I first went and got diagnosed at the hospital, at St George's Hospital. They were trialing it, so they
Yeah.
let me try it for 6 weeks. The only comment I can make from personally, because I'm a tennis coach, so I was using it a lot while I was working and trying to, and I didn't notice any visible difference. But it might have been because I was doing two. They were saying it potentially could work better for somebody who
Or
wasn't as
too
active.
good, yeah. Mm.
Yeah. But it was interesting to use it.
Yeah.
You're absolutely right. It vibrates as you lean different ways. So I can see how it potentially could work, but unfortunately for me, it didn't really make a lot of a difference.
Yeah, I'm sorry to hear that. I mean, it's just, it's as Peter says, it will never replace. The other thing is, and sorry to bang on about psychology, Peter's been discussing sort of gaze stabilization exercises, which sometimes quite often can help oscillopsia, or this bobbing up of the world. There's been a few studies suggesting actually that one's attitude towards what is perceived initially as a horrible sensation, if we can change our attitude towards that and feel more in control, that oscillopsia has much less of an effect on us. And so again, I know this is a big ask, because oscillopsia, as Peter says, is a really sort of unpleasant sensation, but changing our mindset to become okay with that also might make it less impactful.
Debbie, thank you very much indeed, and Peter, thank you for that, and John, hopefully that has helped. I'm going to move on to the next question, because we've got quite a few to get through. This is from Sandra, talking about having read a lot about the brain's neuroplasticity and research on chronic back pain in Colorado, which includes changes in the prefrontal cortex, nucleus accumbens, and the anterior insulation on MRI after pain reprocessing therapy. And if there's no structural damage, the chronic pain being merely the brain's opinion, which has got rather too good at sending unnecessary, outdated signals, she says, of pain to various parts of the body, and in her case, vestibular migraine, then should I stop taking her medication, duloxetine? And will new research on chronic conditions do you out of a job, Peter?
Hope so. Duloxetine is an SNRI, and you'll probably be more familiar in the group with SSRIs, such as citalopram and sertraline, which are antidepressants. So duloxetine is a different form of antidepressants. And one or two people in the group, I'm sure, are on venlafaxine, which is more similar to duloxetine. Should you stop taking it? Well, I most definitely can't say that to you, because there are an awful lot of reasons why you may be on it, or you may need to come off it. It is one of the class of medicines that helps particularly with triple PD, persistent postural perceptual dizziness. And there is increasing awareness that the SSRIs and SNRIs can also help with vestibular migraine. And you use some interesting analogies there to define or to describe what's happening in vestibular migraine and triple PD. And there are lots of different ways of thinking about it. And a sensory overload is one way, and the brain putting too much weight, for example, on the visual information that comes in, or the way the brain processes the information leads to an overload. And by taking those medications, we can somehow suppress that. So I think that these medications do have a place in the management of many of the chronic conditions, vestibular migraine and triple PD in particular. I've got a number of patients who have responded spectacularly to these medications. And some people don't. And I think one of the other things to remember is there is a lot of research, again, ongoing. It's really difficult research to do, because you need really big numbers of people. And it's very difficult to get pure triple PD or pure vestibular migraine from a technical point of view to do the research. So what we end up doing quite often is trialing one medication, if that's going to be one of the routes we take. If that doesn't work, we trial another one. So the answer is, yep, these can be helpful. No, I don't think I'm going to be out of a job soon, sadly. But if I were, I tell you what, I'd be very happy.
Thank you, Peter. We're going to move straight on. We're going to move straight on to the next question. And Debbie, this one I believe is for you. I have a devastating balance problem for the last 3 years. Received great medical care, but I still suffer from panic attacks and general anxiety. I'm wanting to try mindfulness as a way of helping my life, but my partner and child think it's all nonsense and it's a bit of a waste of time, might turn into a hippie. What have you got any advice or suggest any resources to show my family that perhaps they can support him?
Yeah, that's really difficult, isn't it? And I'm sad your family aren't a little bit more supportive. But maybe that support is not there because they don't really understand. And years ago, we did all think about mindfulness, you know, sitting on a mat and sort of chanting away. And the mindfulness that we teach, and there's nothing wrong with that, but the mindfulness we teach these days is completely secular and is done it's all about bringing awareness. And through awareness, we can change how we respond or react if that's not the most helpful thing that we're doing at the moment. I was having a look to see if I could find anything. There isn't per se a document I can find how to make tell your family about mindfulness, but there's lots of good websites. So I teach on the Breathworks mindfulness website, and that tells you a little bit about mindfulness. And there's another Oxford one as well, tells you a little bit about what mindfulness is. So you might want to sort of point them in that direction. There's also a lot of little good YouTube clips just to sort of get them understanding that it's not hippy dippy. I hope you don't think I look hippy dippy. And, you know, there's actually quite a good evidence base behind. So just as you might not take a medication without a study showing that it works, there's quite a good evidence base, less so for dizziness, unfortunately, but I conform to sort of chronic pain, and that's where I take my stuff from. I think chronic dizziness is very much like chronic pain, potentially has similarities. And so there is good research for chronic pain. There is good research for chronic, for recurrent depression. And so it's increasingly an evidence-based thing. I think sharing things where people have been skeptical. So Dan Harris, I don't know if you've heard, he's written a book called 10% Happier. He was a sort of American newsreader who again was quite skeptical, and now his life's been revolutionized. Someone else is Sharon Harvey, again, who there's a good film that My Year of Living Mindfully, which sort of goes through this kind of thing for people who are a bit skeptical. And at the end of the day, if they don't understand, then just carry on and do it, is what I would say. And I hope they do get on board, but I hope it's more that they don't quite understand what mindfulness is, and they've got a wrong perception of it, like it's some, you know, that we don't use. It's not the same as it anymore.
Thanks, Debbie. Lena's also asked a question just on the chat about Zoom mindfulness sessions. So if anybody is aware of those, then if they want to share them in the chat box, that would be fantastic.
Absolutely. So these two places that I've talked to you about, Breathworks and the Oxford mindfulness place, they have weekly, and I'll share the links to that. They have weekly sessions which you can just join for free if you want to give it a go, so you don't have to spend a lot of money. We have a mindfulness community of practice on Breathworks, of which I do have a dizziness and tinnitus group. Now that's more for people with confirmed practices, but again, feel free to join that to learn a little bit more. And maybe if some of your partner, your family joined that, they would learn a bit more about that. And I put all these links in my thing that I'll send to Kevin.
Thank you. Another question then, from somebody who didn't want us to give us their name. I've had severe dizzy spells infrequently over the years, seem to be getting more problems this year. Generally, my GPs have in the past, currently different GPs, currently trying to tell them at the moment, or they tell me that that it could be a virus, a cold, or minor ear infection, and I feel like they just want me to go away, or things will get better by themselves. So this question is about, can anyone advise me on what to say to my doctor to try and get them to take me seriously after so many years?
It just drives me crazy. It's just, you need referral to someone who knows about balance. I mean, much the commonest cause of episodic dizziness that comes and goes is BPPV, benign positional paroxysmal vertigo. So if you are listening and you get dizzy, if you lie down in bed, roll over, get up in the morning, look up, it's BPPV. Good starting place is to start taking vitamin D over the winter months, if it is that, for example. But you need referral to someone who knows what they're talking about. So you need referral to a balance clinic. It's really straightforward. And, you know, each year I'll see someone just using the diagnosis of BPPV, who's been symptomatic for 30 years. And we've had several people through who've been symptomatic for 40 years, undiagnosed, giving exactly the same story that you give. Now, there are a whole range of other potential causes which need looking at, from cardiac arrhythmias through a whole range of other things. So these are not symptoms that should be ignored. They should be referred. And I don't think there's any excuse for not referring.
I think the problem is that, you know, GPs have got so much on their plates, and they can't be master of everything. And so throughout my career, I've really tried raising awareness amongst GPs, but at the end of the day, they've got sort of too much on. So there needs to sort of be clearer pathways. And we've tried within our area to say, right, X, Y, Z, refer to us, A, B, C, refer to ENT, etc., etc. But I really would just, I completely agree with Peter. It drives me crazy. And you just need to somehow put your foot down and say, I'm really sorry, I've been ill for a long time. Please, could you refer me to wherever you feel is appropriate? And it's so difficult getting past receptionists these days, and all these online phone appointments, which are good in GPs, but you know, sometimes you need a face-to-face. You need to say, please, I need some help, and just, you know, put your foot down.
Can I just ask you both, where does a patient stand almost legally? Can they insist to have a referral, or can they just be fobbed off by their doctor?
I don't think they can insist, no, because in the UK, it is a problem with the UK healthcare system, isn't it, that GPs are gatekeepers. And in many other countries, they're not gatekeepers. You can go direct to the specialist.
Yeah.
It's very
Fair enough.
It's a really
my advice, and I know not everyone can do this, but if you want that referral, you just become the biggest pain in the backside you can be until they refer you, because you've got to go forward and see these people. I know not everyone likes to do that, but I find not literally banging a desk, but insisting, and generally they'll want to get you out of their way and refer you. But it is a shame, as you both said. I've heard this for years, where people suffer unnecessarily for so many years because they never get to see someone who understands what they're going through.
Lena, I just want to add in though that Lena's just put in the chat that there are lots of let's not diss our general practitioner colleagues who've been doing an amazing job.
Yeah.
So Lena just said that her GP understands about BP and vestibular disorders. So there are many, many, many. And so that's great. But because it's such a specialist field, you can't expect them to have all this knowledge. So just making that onward referral is what we're asking GPs to do.
Yeah, true.
Brilliant, thank you. Got a question from Tom, who is a new member of the support group. Well, welcome, Tom. He wants to ask Professor Ray about central vestibular disorder. He was diagnosed with, and please forgive my pronunciation of things, cerebral amyloidosis 3 years ago, and when I began to feel lightheaded and sent for a brain scan by a neurologist. He saw a private neurologist who has investigated brain scans, and his opinion that it was central vestibular disorder that was causing this lightheadedness, and that there wasn't anything that could be done, but he wanted to see a private cardiologist at the Spire, which he did, to make sure his blood pressure was controlled. That I understand has improved. The private neurologist has also said that he should see a neurophysiotherapist who he's been seeing for a month or so. He also has an underactive thyroid, which he takes medication for. So the question is that he'd like to know if he can be helped with this debilitating problem, as it's very stressful and frustrating. Peter.
Well, yeah, I'm sorry, Tom. That's a difficult diagnosis. I think that there's two parts to this. One is a specific answer. It's your GP is doing exactly the right thing. Amyloid is an uncommon condition. It can affect the brain, cerebral amyloidosis. It can affect the heart, which is why they wanted you to see a cardiologist, because you can get cardiac amyloid, which can lead to low blood pressure and various other things. So that's a specific thing. But if we look in general at central balance disorders, the older you get, the more likely you are to have a central contributor to your balance disorder. And a lot of patients we see will have mixed central and peripheral balance disorder. So the first thing we need to do is establish, is this purely a central balance disorder, or is a component of peripheral balance disorder, i.e. in the inner ear, or other elements, for example, peripheral neuropathy, numbness in the feet and so on. And we do that generally by clinical assessment, and if we need to, we can supplement that with balance testing. And if there is evidence of a peripheral component, then you may well respond well to dedicated vestibular physiotherapy. Now, we have a number of patients, quite a number of patients with strokes, MS, and a whole range of other central balance disorders who do actually respond in part, not brilliantly, but in part to vestibular physiotherapy and other types of balance rehabilitation. So in my opinion, it is worth assessing this from a vestibular perspective. Some of the neurophysios can give you some of these exercises. That's not an unreasonable. I think sounds like you've been managed well here. But having a formal vestibular assessment may well complement that, and you may find there are other routes as well to help you, not cure you, but help you. And that's the same on a general pattern for those with central balance disorders. There's very often other components to it. So we have this concept of the multi-sensory balance disorder, where a central element is just one component of it.
Yeah, and you know, I think Tom was saying that it's impacting his social life. He just wants to be able to do normal things again, like go to a cricket and football match or even music events like he could in the past, Peter.
Yeah, and I think that's reasonable. And there are two ways of looking at that. You can look at it from the medical perspective, saying the diagnosis is A, B, C, and these are what the treatments are. Or we can look at it from I'm dizzy and can't function perspective. And there may be adjustments to life. And it may be that a walking stick or a frame or a wheelchair or a special section of the venue is appropriate for you with adequate support. And I see absolutely no reason that you shouldn't be able to get to those functions with the appropriate support. And having a formal written diagnosis and then the support of occupational therapist or your GP or whoever's appropriate to support you in getting access to those venues, there's absolutely no reason you shouldn't be able to do that.
Thank
and
you,
I think that's really important, because you have all the things that you love. You don't want to stop doing them. You just may need to think outside the box. How can I still do these things that I love, but maybe in a slightly different way, just as Peter was saying? And there are so many different ways we can do things. We're very sort of creatures of habit. We can only do this if we do it this way. But actually, there are lots of other ways we can get to a football match or do the things that we love. So taking that kind of broader perspective. And again, you might need some help to do that with a physiotherapist or occupational therapist, get some devices to help you, and to really try and keep positive and work out how you can do those things that you love doing.
Thank you. Thanks, Debbie. Geraldine has a question as well. I understand that when taking I can't pronounce this, I think. Venlafaxine for triple PD and VM at a level of 75 milligrams or more, you shouldn't take it more than a year. Would the same apply if you were microdosing on a very small amount, around 3 to 5 microbeads per day? How long would it be okay for to take it in microdose form?
So venlafaxine we've mentioned in terms of duloxetine as well. Venlafaxine is the drug that I tend to recommend and have more experience of. The research has suggested that a 12-month course is appropriate. It can be difficult to come onto, and it can also be difficult to come off. We've had just 1 or 2 patients have brain zaps and other difficult things coming off it, but everyone's managed to come off it. We tend to start at a low dose of 37.5 milligrams a day and gradually build up. And after about a year, generally I ask my patients to tail off it and then gently come off. It's not prescriptive. You can take it for more than a year. The reason we use these lengths of time is to try and give you an endpoint to work towards, and it's better not to be on medicine long term if you can avoid it. And you can take it longer under the guidance of your GP. All of the drugs have side effects, so you need to speak with your GP if you're going to take it for longer. Now, the second part of your question is interesting, and the simple answer is neither I nor anyone knows the answer to whether these microdoses, this is opening up the capsule and taking the microbeads in there. There's no research evidence to say that that is beneficial in these conditions, and I have no idea at all whether it's any safer or less safe taking it long term, and neither does anyone. Because when you do research, we can't salami slice the research protocols. So we can't have 50 people on 1 bead, 50 people on 5 beads, 50 people on 37. Just in the real world, it's not possible to do that sort of research. Presumably, the lower the dose, the safer it is. I would be pretty cautious actually, but I would give the same guidance taking low doses, mid dose, that if you can come off it at a year, it's better. But if you can't function off it, it may be worth speaking to your GP to see if you can take it longer term.
Thank you, Peter. Sylvia's question is about her balance problems, but more with a throbbing, moving head that is with me all the time, she says. I've had it for many years. I feel that I know it's MDDS, as it started after a boat trip. Who do I go to and where do I go for a diagnosis, as GPs and some ENTs aren't aware of it?
Should I take that one? You're right, me taking that one. Yeah. So MDDS is Maulder-de-Barcamon syndrome, and it's one of a spectrum of disorders that we see in our patients with chronic balance disorder. Now, one of the things I'd really ask is that everyone's really careful with diagnostic labels. So there are a spectrum of disorders that can cause chronic imbalance. It's not like having appendicitis or a heart attack, which are really very specific diagnoses. And the same goes with triple PD, persistent postural perceptual dizziness. This is a term that's been put together to describe a cluster of symptoms. Now, MDDS, Maulder-de-Barcamon syndrome, classically comes on after travel. So after a boat trip would be the classical one, but it can also come up to car journeys, trains, air travel, and so on. And for most of us experience those symptoms. You know, if you've been on a boat, ferry across the channel, you feel a bit funny as if you're still on the ferry when you come off the other side. But some of our patients experience that long term, and a very, very small number, it is specifically related to the maladaptation to that motion. You can sort of imagine, if there's just a way of thinking about it, there's a gyroscope in the brain, and when you get on the boat, you feel dizzy, then the gyroscope starts moving with you on the boat, and then it carries on moving with you when you get off the boat, so it causes those ongoing symptoms. Now, your question is this the diagnosis? Well, there are a whole bunch of other things that can cause those symptoms as well. That's the problem. So you can have an acute vestibular event or a chronic vestibular event. In other words, you can have something wrong with your inner ear. And many people describe the same symptoms as MDDS as a consequence of inner ear disorder and as a consequence of other disorders. So my answer to your question is, you need to get a proper diagnosis. Be really careful on self-diagnosing. You need to, because if we read stuff on the internet, suddenly, that's what I've got. But it's so often not the case. So you need to be seen by someone with expertise in balance. It might be an audiovestibular physician, it might be a neurologist, it might be an ENT surgeon like me, but it has to be someone within one of those specialty groups who has a particular interest in balance disorder, and that's the person you need to seek out. And I really would be very careful about making a self-diagnosis.
Yeah, I completely agree with Peter. It's so easy to do. I'm sure I would do the same thing. We Google and we come across our symptoms and we self-diagnose, but getting that diagnosis and having the balance function testing is really important. And then if it does, then you know where you are. Sometimes I just say, actually in my work, it's kind of what's more important is ruling out sort of things that we need to be concerned about, because quite often in chronic dizziness, there is nothing structurally wrong with the balance system. And so we should be really delighted about that, because we don't want something structurally wrong with our balance system. And then we've got what we call a functional problem. So where there's no structural problem, but the system is misfunctioning. It's a sort of processing problem. It's a software problem. And so this is what a lot of this term chronic dizziness, we've got Maulder-de-Barcamon, we've got 3PD, we've got chronic subjective dizziness, we've got a whole lot of different things, motorist disorientation syndrome, they fall under this because actually we haven't got anything structural, which is great. So, ruling out or seeing whether you have got anything wrong with the balance system per se, and then moving forward, even if you can't get classified into Maulder-de-Barcamon or whatever, I think is definitely the thing to do. And then actually, it doesn't really, when you have chronic dizziness, there's not a huge amount of difference between what we do for these different subtypes. And the subtypes overlapped, and they overlap with migraine, and they overlap with anxiety. And so this focus on, I've got this, sometimes isn't helpful. Rather than I've got this is, I feel like this is what I'm going to do to get over it.
All right, Debbie, thank you very much. We're Slightly running behind time, so if you could keep your answers a little bit shorter, I'd really appreciate it. I'm going to go to this last one before we take a bit of a break. This is a question from Rosie, who says, I'm pleased to have the opportunity to ask a question. I've had dizziness for almost 2 years now. In November last year, I saw an ENT specialist privately. He was actually the leading NHS ENT specialist at my local hospital, although I have never seen him before. He did an MRI scan on my brain and cervical spine and diagnosed a cervigenic problem. I've been attending his clinic every 6 months, as 20 years previously I'd had an operation for something, which hopefully you can pronounce, Peter.
Yeah,
Oh,
and you're not allowed to be seen.
A cholesteatoma, yeah.
That's really shocking, actually. So you've presented two different problems here. So the first is you've been told you have cervicogenic dizziness. So we normally talk about balance being a result of information from your eyes, from your ears, the vestibular bit, and proprioception from your joints and muscles. But your neck also sends nerve impulses to your brain. And the big literature on this is following whiplash injury. So we know our patients who had whiplash injury, hit the back, may get a bit of vestibular injury and neck injury, recover much more slowly. And that really can respond to a range of different forms of physiotherapy and muscle relaxant medications. The thing that, and I would absolutely see a patient with cervicogenic dizziness in my clinic, because I think I can help better than most other people. But what really troubles me here is you've had a cholesteatoma. Now, cholesteatoma is one of my other big hats. So I often do 2 of these, in fact, routinely do 2 of these surgeries a week. They take 3 or 4 hours each, and it involves drilling out the skull, going deep into the head, and taking out skin that's eating into the ear. Now, the thing is, that disease and the surgery associated with it can cause weakness of inner ear balance function. And if that's added to a cervicogenic dizziness, well, then that's really difficult to get better without treatment. So I really think you ought to be seen in a balance centre. And the team in Norwich is really good. You could try and get in touch with John Phillips, who's the lead expert there. And he's a great guy to go and see. And I'd see if you can get in touch with him and see him locally. He's an ENT.
Can I just say something? The team in Norwich have refused to see me because they don't treat anybody with cervigenic diagnosis.
Yeah, no, that really, yeah, no, I read and I'm really surprised. But my point here is that this might not be cervicogenic dizziness on its own. It may be secondary to a labyrinthine disorder, an inner ear disorder, because if you have cholesteatoma, it can eat into the labyrinth. Presumably it hasn't because you had it a long time ago. B, yeah. The surgery for cholesteatoma can involve touching the hearing bones, which can cause weakness of your labyrinth, of your inner ear function. And thirdly, if you have a cavity, a mastoid cavity following cholesteatoma surgery, then any inflammation in that cavity will cause inflammation of the inner ear balance organ and cause destabilization. And I just wonder whether the referral letter wasn't correctly worded. It may have said, can you see this patient with cervicogenic dizziness? But actually it should have said, can you see my patient, please, who has dizziness, who has a history of neck injury and ear surgery? And in that case, they would see you. So I think I'd ask your GP to reword the letter and ask for it, because they're good people there, and really genuinely good people. And I think it's probably a problem of interpretation of what the letter said.
Okay.
Thank you both.
Good
Thank
luck.
you very much. We've got lots more questions to get through, and we will do them very, very shortly. And if you've got any questions at the end, then we will definitely try and get those answered as well. But of course, we're going to take a bit of a break now, Kevin.
We are. Hopefully everyone can now see the screen. Can you see that, Rupal, Kelly? Is that coming through?
Yeah.
But we're at that incredibly important time of year for the Dizzy Awards. It's where we like to acknowledge people who've done something a little bit special for our balance community. Professor Ray is actually a previous recipient.
Actually, Kevin, could you just put me on the screen?
I will try.
Just flip me back, flip off the thing just for a second. I have something very.
Let me. I'll tell you what. Let me just. If I stop, there you go.
Oh, yeah? Okay.
You can see you again, Peter.
I just want to show you. It's sat by my desk. It's always sat here. I have my Dizzy Award. And I have my Dizzy certificate.
Good.
I have it sitting here right by my desk every day.
Peter, rumour had it, it was your award that helped your next position as the president next year.
Royal Society of Medicine. It may be the case.
Right, thanks. Let me try and re-share. So the Dizzies, it's about acknowledging the great and the good. The judges panel includes Kelly, Rupel and myself. And it's very difficult because there's so many people do so many things throughout the year that help us all. There's so many members that contribute as well. So we're just going to dive in and say there has to be winners, and you're about to meet some of them. So straight into the first category, if I can get that to work. Kelly?
Okay, ready? So our first award is for outstanding contribution to the support group and its members from an expert clinician. And the winner is?
And the winner, and just to mention, it really is awfully difficult to judge this because we get so much help every year.
Yeah.
But we are looking for those things that are new and different in the year. And the winner is, would you believe, Debbie Kane is the winner of this award. And the reason for that, Debbie and everyone watching, we felt your presentation, what you shared with us on mindfulness, was awesome. It was brilliant because we have had people mention mindfulness before, but not from a position of understanding all about balanced conditions. And we found there was a difference there between what you could say is a generic look at mindfulness, but yours was very specific and tailored to how we could use it for the challenges we face. So we thought that was brilliant. So congratulations on winning your first Dizzy. And you are allowed to make a very short speech of acceptance.
Well, yeah, thank you. I wasn't expecting that at all, but I'm glad that I passed on some useful knowledge, and I hope I can continue doing that. That's what I'm about, passing on, empowering people to use mindfulness and other strategies to live well with. So thank you. That's kind. I don't think I've ever got a reward before. No, I did it once.
and just for anyone watching, we will put it on. There is a link on the chat already where you can see Debbie's presentation from earlier in the year. It's well worth watching, really is for everyone. And now to the next category, Kelly.
So our second award is for a best balanced friend of the year, and it goes to somebody that is not currently a group member.
Yeah, and that's really about people that are helping a member above and beyond, really, doing something that is really making a difference for them. And the winner is this year, Sue Weller. Now, Sue was nominated by Helen, and I believe Helen is with us, so we'll go to Helen in a minute. Sue couldn't be here, but we have written up on that slide the reason Helen nominated Sue. And it's just lovely to see others, whether they're professionals or just good friends, it's lovely to see people recognise where they can offer that additional help and support, because boy do we need it sometimes through the years with balance challenges, and it's very difficult to find those that understand exactly what it is we go through, because we all look so well, we don't have bandages on our heads. So Helen, could you just say a few words to us about Sue, as Sue's not here? If you would mute. There you go.
Yes, I've known Sue for over 8 years. And when I was diagnosed, firstly with my acoustic neuroma, but then secondly started to have some challenging vestibular issues, I was being doubted in the NHS and finding it very difficult to access vestibular rehab. And Sue has always been on hand, offering her wisdom, her advice, and I'll be forever grateful for that. Particularly as her partner died it was actually 2022. Yes, this year when he died in January 2022. But Sue's continued to work tirelessly in her McTimoney chiropractice to help people like myself.
Lovely. Thank you very much, Helen. It's great to see. And the next category, Kelly.
Yeah. So next up, we have got a group member category, and it is for the best balanced friend of the year. So it's from a member to another member who's gone above and beyond the call of duty and made a positive difference in their life. And the winner is?
The winner is Steve Watkins. Steve, well done. Nominated by Faye Gray. As I won't read it all out there, and this will be shared with everyone after the meeting. But it's amazing to see a relatively new member diving in there and helping another member and sharing their experiences, their knowledge, their resources, and just by that contact, giving that support to each other. And it's what we're really about as a support group, is trying to connect as many members with other members, so that what we're doing today with Professor Ray and Debbie's brilliance in getting the expertise, but there's so much you can individually do for each other just by being there and talking about things. And a lot of it fills that void between clinical appointments, where we can discuss how do we cope, how do we get on with our lives, how do we cope with the small stuff that you can't take to a balanced expert. So really brilliant. Well done, Steve. Thanks, Faye, for the nomination there. And I think, Steve, we've got to go over to you and have a few words from you, please.
Hi there. Yeah, that's I'm very touched, but don't feel I deserve an award. But thank you very much indeed, much appreciated. But I've gained so much just from talking to people in the group, and I couldn't recommend that enough, because, as I think most of us feel, it is quite an isolating experience. But I think I've gained so much from talking to people and making some good friends. So thank you, much appreciated. Thank you, Faye.
Brilliant. Well done, Steve.
Thank you.
Kelly?
Okay, so next up, we have got the award for Outstanding Member Contribution of the Year. So it's given, this member has given us insight, hope, inspiration, that we can all get to a better place no matter what our condition is and how dark some of the days may be. So, and the winner is?
The winner is, drum roll, Claire Morgan. I think you're there, Claire. Why, Claire? If you were tuning in to the previous meeting, you would have seen 5 members share their stories. And we felt Claire was so good at explaining the initial stages of having the condition, but then giving that honesty, and we thought quite inspiring, of how she slowly got to take control, more and more control, and it was a journey of patience that I know she'll say she's still on, to get to that better quality of life. So we just had to applaud that sharing with us, and we think Claire's story on that video will go on to inspire quite a few others to really go for this and tackle it until you get to that better place. So Claire, if you could unmute, we'd just like your acceptance speech, please.
Well, I'm speechless. I'm not sure I really deserve it, but thank you so much. It's been so lovely to discover this support group, and how much it would have helped me when I was really bad as well. I'm so glad it's now here for people, and it's so interesting also learning from all of you about your experiences and feeling that sense of connection with you all. So yeah, it's a great discovery, this group. Thank you, and thank you very much for this award. Thank you.
Well done, Claire. And honestly, it's the sharing, the contributions that make us what we are. It really is. Without all of you, we're nothing. So well done and congratulations. And we've now got the final category, Kelly. If you can do that.
Tense moment now. Final award. Who's it going to go to? So the final award is for Best Members Personal Journey. So this one is a new award that we've added to our list of awards this year, and it recognises the importance and the group goal of fostering in all of our members' personal growth learnings about their conditions, and ideally seeing an improvement in their condition and quality of life. And again, it very much is about sharing that personal journey with all of us and how it makes such a positive difference to us. So the final winner of the Dizzies today are...
The winner is Faye Gray. I love that response, Faye. We'll be using that in marketing clips. That is great. Faye, again, we've got Faye's own words there. And it's what the support group is all about, is trying to accelerate that journey that we're all on of speeding up the learning, the support, feeling that you're not alone and enabling you to feel that you can take all of this on and you can defeat it. So it's what we're all about, and so good of you to share that with us, Faye. So we're delighted this year to give you this new award. And by the way, before your acceptance speech, I must add to all the winners, sadly, there's no cash, there's no chocolates and there's no flowers, but you will get the Dizzy Award posted to you in a week's time, which hopefully, as Pete said, it can stay there and remind you. But Faye, well done. And if you can give us just a few words of your acceptance, that would be lovely. If you can unmute.
Well, I'd like to thank my family and my friends for sort of bringing me into this world and everything. Yeah, no, it's really lovely. I wasn't expecting it at all. I knew obviously that Steve was getting his, so that was, yeah. So I was chuckling to myself when he got his, but I'm slightly embarrassed, but yes, thank you very much.
Well done. Thanks for showing it. And again, we hope it's just inspires others to put as much in as you can. I know it's difficult when we are feeling absolutely awful, but on the good days, try and put something into the group and share with others and contact others. And I think it's the usual thing in life. The more we're able to put in, the more we kind of get out of things. But congratulations. And really well done to all the winners. And all of you members, because say you're all part of this, and we're just over the moon that we can give these little Dizzy Awards out, and one day, who knows, there might be cash, flowers and chocolates, but at the moment it's just the award. But thanks very much, and now back to part 2 of the questions, Rufal. Thank you.
Shameful. It's the cost of living crisis. No chocolates, Kevin. Honestly, it's Christmas. It's outrageous. But congratulations as well from all of us. Well done, and thank you for being part of this group. I'm going to crack on with the questions because we still have quite a few to get through, and I know people have got stuff to do. So, Debbie, this one's for you. Kevin says, I'm a convert to mindfulness. In his younger years, he thought it wasn't for him, but I think that Kevin would like to continue doing a bit of mindfulness. But what's the easiest way to do something each day or each week, to remember to do some?
Yeah, so we are all so busy, aren't we? And I think it's good that you've realised that you're not doing it. There's so many different ways. I mean, things like alarms on phones, you know, just you're going to take a little bit of time out, maybe once or twice a day, alarm goes off on your phone and you have a meditation there that you can do on your phone, or even on some of these apps, and there are some very good apps now, I had an app once which said, right, take 5 breaths with full awareness. Well, that is you being mindful. Do also remember that you don't need to meditate to be mindful, and you can do activities mindfully. You can brush your teeth mindfully. You can eat your dinner mindfully. You can drink your cup of coffee mindfully. You can watch the kettle boil mindfully. So it's not just about meditating on a mat, so to speak. It's about how you go about things with full awareness. Just walking can be mindful. You could zip from A to B, or you could think, what am I hearing? What am I seeing? What am I feeling under the feet? What am I thinking? So there's a whole lot of ways that you can do things mindfully, and you can incorporate mindfulness into your life, but you really need to get into a routine. And that routine, especially if you've got a busy life, it can be very difficult. So sometimes you just need to carve out some extra time, you know, have a morning meditation, just set your alarm clock 10 minutes before you normally get up. I had the greatest success with this one because I'm bad at my evening meditation, but my morning meditation, I get up 10 minutes before I need to leave, and I always do it. So part of it is finding some strategies that work for you, and part of it is to think more sort of laterally and about doing things mindfully as well as meditations. And I've got a little article which I'll put in the I'll put in the links when Kevin sends it. But keep on going. But you do need to make time.
Thank you, Debbie. We've got a question from Nikki, who says, I'm currently under the care of the LRI Balance Clinic and would like to know the process of being referred for CBT. Is that through the Balance Clinic or the GP? I have triple PD, vestibulopathy and migraine, Peter.
Through your GP. We don't have a direct link, unfortunately. We should, and in an ideal world we would, but we don't, so through your GP.
Thank you. Question from Julie says, having shared my experiences in treatment of many years with others up and down the country, there seems to be a lot of variation in types of treatment now, some more successful than others. Great that there are so many new treatments, but is it a bit of a postcode lottery now, Peter?
No, it shouldn't be. I mean, the evidence is pretty good, and we lecture and teach on this a lot. The evidence, I mean, there are a very wide range of therapies available, that's true, and I agree that there are different opinions between experts, but they're pretty similar. So the concept that you should have a low salt diet is fairly well established, but very weak on an evidence base. The evidence base for beta histone or circ is very weak indeed. It may be that some people are helped by it and can use it. Diuretics, maybe some people do prescribe them, some don't. The evidence base is very weak. The evidence for intratympanic therapy is injecting either steroids into your ear or gentamicin in your ear is very strong indeed. And if you want to read that, if you haven't, you can look up the Lancet paper that I co-authored in 2016. So if you Google Lancet and Meniere's, and if you put my name in, REA, and if you put, say, Bronstein, BRONSTEIN, if you just Google that, we've paid for that to be on open access. It is a scientific paper. But you can see that injecting steroids or gentamicin lead to an average 90% reduction in vertigo over the 2 years after treatment. There is a range of opinion over the steroid. I prefer solumedrone, which is a bit uncomfortable sometimes, but a very powerful steroid. Some people use dexamethasone, which is a much lower concentration. And then if they don't work, there are surgeries. So if you have vestibular nerve section, cutting the nerve between your ear and your brain, there's a very, very high likelihood that'll stop the vertigo attacks. But there are significant risks with that, so we do that very rarely now. And there's endolymphatic sac surgery, and I think endolymphatic sac surgery, where we can remove the sac or clip it, that's the one area where there is some controversy still. But given the benefits, and most studies report about an 80% reduction in vertigo attacks, 80% of people having a reduction in vertigo attacks following this treatment, and 50% having no further attacks. Given that those data are significantly lower than the intratympanic therapies, there shouldn't really be too much variation in care across the UK. So for most people, it's if general lifestyle and advice guidance doesn't work to start with, the intratympanic therapies for most of us would be the next line of therapy. So no, there shouldn't be too much variation.
Thank you, Peter. I'm going to crack on with the next question, and this is, I think, a bit of both of you. Debbie, if we can start with you with this question. This person can't attend the meeting, but will be watching it back. It's basically about whether there is ever an opportunity, you think, that all the different expertise, diagnosis, treatment, rehab, counselling, aftercare, mindfulness can be joined in some sort of coordinated way for balanced patients, or is that something that perhaps is a long way off?
Well, I think it very much depends on your area, and I completely agree this is the way forward. Well, it shouldn't be the way forward, we should be doing it now. Multidisciplinary care has been in the NHS, the concept, for years and years and years, and it's very sort of, unfortunately, a postcode lottery. It works very well in things like cochlear implants, Peter, doesn't it, where you have a sort of multidisciplinary team allocated. In the world of dizziness, unfortunately not so, and people tend to get passed from pillar to post, which is not the best journey for you. I'm hoping that actually with the advent of Zoom and us using that much more extensively, I've definitely had some liaisons, some multidisciplinary appointments with psychologists and a patient, which would have been much more difficult because we're all at different hospitals. And so it would be sort of postcode specific, and you can see if you can access it. And I do very much think it's the way forward, not necessarily having all the clinicians in at the same time, but having someone where we have this network of care where you have a coordinator and then someone coordinating that multidisciplinary approach.
Yeah, I mean, I worked with the Department of Health 15 years ago on this, and our recommendation was very clearly to have a regional czar, if you like, for balance, and have a regional balance centre. And that's the problem, that this hasn't been set up, and it needs to be a hospital-led balance centre with all the disciplines that you mentioned there. You know, in Leicester, in our Leicester Balance Clinic, we have everyone bar the psychologist and CBT. So we have all the diagnostics, we have the ENT surgeons, we do joint clinics with neurologists, we have the audiologists, physiotherapists, investigation tools, mindfulness, all of that. Everything's under one roof, and that's the ideal. And then if we have a very tight network of friends, we have a group of consultants we call the spin doctors, and there's me and a geriatrician and a cardiologist and a neurologist and a physiotherapist and an audiologist and a breathing specialist, and we all get together. So there are virtual clinical networks and physical clinical networks, and that's absolutely the right way to go. And in private practice, in Leicester, at London Road Clinic, we have everyone under one roof. So we do work this, and this is worked in many centres. Manchester's a very good centre as well, as you've discovered. And there are a number of real centres of excellence around the country. But unfortunately, this really is a postcode lottery. And that's a big problem. But we are working really hard. And I've done a series of lectures at the Royal Society of Medicine, worked Department of Health. We've done lots and lots of work to try and get this rolled out through the country. So this is best practice, but also I think it's fair to say it's not practical to have all of the clinicians in the room at the same time, because that's very, very expensive. And when you have limited NHS resources, that's something we would really struggle with. And I don't think any healthcare system can cope with that. But having virtual and physical centres of multidisciplinary care is without a shadow of a doubt the way we should go forward.
Right, thank you. Richard asks, what is the general cause of chronic migraine, VM and triple PD? Can it be caused as a result of a nasty chest infection? Can mental health issues building up over a period of time like PTSD cause it?
Deep breath. Okay, if you've got a few hours, I can start going.
Carry on, Peter. That's a nice, easy one. Just bullet point.
All right, I think there are multiple causes. So some causes of vestibular migraine and migraine are genetic. For example, there's a gene called the CACNA1A gene, which codes for hemiplegic migraine. You get paralysis down one side of your body, and a condition called episodic ataxia type 2, which is a rare form of episodic dizziness. And if you really want to be very top of the class, spinocerebellar ataxia type 6. So we know that there are a number of forms of migraine that have a genetic predisposition. We know that most people with migraine have a family history. So that's one of the first questions we'll ask you. Do your parents, brothers, and sisters have migraine? So you have a genetic predisposition to get migraine. There's no question of that. And we also know that 10% of migraine attacks manifest as vertigo, so vestibular migraine. And if you think that 15% of the population have got migraine, then 1.5% of the population get vestibular migraine. That's a very, very big number of people, isn't it? So it's not surprising that's one of the big diagnoses we get. And you come on to triple PD. As I said at one of the earlier questions, triple PD is a construct to bring together a symptom cluster. It's not a formal disease process, but it makes diagnosis and management much easier. And it has three principal triggers. It's commoner in people with migraine, it's commoner in people who have a history of anxiety, and it's commoner
to be here.
And it's commoner in our patients who have had a vestibular disorder, such as vestibular neuronitis or BPPV. But it's also commoner in certain personality types. And we've done some nice research on this, showing that certain people's brains can manage risk in different ways. So we could actually give you a card game, and depending on how you respond to this card game, we can predict whether or not you'll get triple PD, for example. So in a way, you're already teed up to have these conditions, dependent upon the structure and the way that your brain functions. Is that a helpful answer? It's a huge, I mean, I can speak for hours and hours and hours and hours on it, but I'm looking at Rupal and I've tried to not.
Thank you.
No, I think that's a very excellent answer from Peter. But I think with the whole 3PD thing, I think it also sort of be useful to say that it's kind of a software processing problem. So you can have vestibular migraine and 3PD, but if we just look at 3PD, a useful way of looking at it, as we're in sort of such a computer age, is that you've got a computer, you've not got a hardware problem. So you might have had a hardware problem, but it's gone away. And now it's a kind of a software processing problem. And so for whatever reason, whether you're predisposed to it or whether stuff's happened in life or whether it's just happened, it's a software processing problem, and that can be changed, that can be fixed, and that can be sorted. It's not quite as easy as rebooting the computer, but there are lots of things that we can do to rewire, to reprocess. And it's not your fault and you're not making it up. There are very, very real perceptual, you know, you're perceiving dizziness, even if there's not an actual cause of it. And that's where I very like the pain model. And so looking at it as a sort of software processing problem, I think is quite a useful way of understanding it.
Brilliant. Another question from Richard. My old GP told me it would be 10 times harder for me to deal with migraine and vestibular disorder than anyone else, as I already had the generalized anxiety disorder, social anxiety, and bipolar and autistic spectrum disorders. Is this often the case?
Yeah.
So I'd just like to jump in here and just sort of say, I'm so sorry that your GP was so negative about that, because that's not really what we want from GPs. I think, as Peter's already alluded to, one is more predisposed if we've got a mental health history or if we catastrophize in an attack. But that's not to say that there's not lots of support that we can do to help support you living as good a life as possible, Peter.
Yeah, that's true. And equally, I mean, I think it is true. If you have other mental health and anxiety issues, you are more likely to struggle with migraine. And equally, if you've got migraine, you're much more likely to struggle with a balance disorder as well. So each of them do play off against each other. And that's why the way I try and manage my patients is always to get each of the diagnoses. It's a medical way of doing it. Identify each of the problems, then try and address each problem individually. And I find that a really helpful strategy for getting everyone better.
So even if you've got a number of things going on, then each of them can be addressed individually and as a whole. So keep positive.
Thank you, Debbie. Look, Kelly, we've had lots of chat in chat. Are there any sort of questions from anyone that we can take very quickly before we ask the panel some final questions?
I think we're doing all right actually for questions. There's lots of general chat, which I'd recommend people to save the chat, because there's some useful kind of pointers in there. But people have been doing my job for me in terms of answering the questions if we've been going along. So I think we're good to go. Just having a look at the last bit.
Is
but
there
yeah,
any?
I definitely recommend people to share, to save the chat at the end.
Is there
Yeah,
anyone that would like to ask a question? Is there anyone that would like to ask a quick question to Peter or Debbie before?
And by the way, everyone, you will get a copy of the chat after the meeting. You'll get an email with a video link and the chat transcript. So if you want to go for it, Rupal, if you go for the panel questions.
Yep, will do. Okay, so this is for both of you. If you could change just one thing in the NHS that would help the most balance sufferers in the UK, what would it be? Let's start with Debbie.
Why are we starting with me? That's very unfair. Well, one thing. I mean, I think it's continuing to try and raise awareness of our primary care colleagues about the dizziness, and how they can best support people as quickly as they can so that we can nip chronic conditions in the bud, like 3PD. Because a little bit of time at the beginning and maybe not using lots of medication and referring on to someone who can just maybe give one appointment to say what's happening and how to get over it, I think would be really useful in preventing. I think all this 3PD, a lot of it is preventable. And I know that's a big ask because GPs are so busy, but I think that was what I would say: education and raising awareness.
Peter?
You know, I'm really clear what I think. We need dedicated balance centres in hospitals to cover each region. We've tried it in general practice. We tried this after our Department of Health works 15 years ago. It didn't work. And we need dedicated experts in each region. And unfortunately, there's lots of regions in the UK who don't have that. And patients in those regions in particular are in a really difficult position, and that's not fair.
What are your top 3 tips for having the best Christmas with a balance condition? Shall we start with Peter? Let's go with Peter.
I think it's a difficult one, isn't it? But I think having a supportive friendship network is really important. And Life on the Level is one of those supportive friendship networks that you can have. So they can be in any form. And being isolated is a bad place to be if you've got a chronic illness. I think you need to have some time for general fitness and exercise, even if it's walking on someone's arm, getting outside, getting some sunlight on your face and on your skin, just to keep healthy is really important. And obviously really enjoy Christmas, but don't overdo it because red wine's bad for you.
Don't be a spoil sport, Peter.
Oh, Peter.
I've ruined Christmas.
I've got to say, Peter, bar humbug.
Yeah, exactly.
I love my red wine. It's kept me going on many a...
Everything in moderation, everything in moderation.
Yes.
Debbie, let's come to you.
Yeah, so I would say, again, taking the more sort of holistic approach, think about it before you get to it. So have a strategy, and that strategy needs to include pacing and resting. Yeah, there's going to be more to do. There's going to be more people around. So how can you ensure that you don't boom and bust, rush around all over the place, and then have an awful day because you're too tired? So in the days before, make sure you have enough rest, have a little strategy of when you're going to do what, ask for help. Yeah, you don't have to do it yourself. And let people know. If you let people know that you have this hidden disability, I feel sure that they will, and that you need rest and that you need help. I feel sure if you're getting a bigger gathering together, then they will want to help. And it's because people don't know what you're going through. It's this hidden disability. And then finally, without being bar humbug, it is one Christmas. Yeah. And so there hopefully will be plenty more Christmases. So sometimes we set our expectations up so high for this one day, and there'll be another opportunity. But I hope with all those kind of things that you'll have a fantastic Christmas.
Kelly, I know we've got a question that we want answering very quickly before the very final question.
Yes, it is from Richard, and he would like to know, I've lost it. Hang on. He wants to know, what is nystagmus and how it can be cured? It's one for you, Peter.
Nystagmus is jerky eye movement. So if I'm in a spinny chair here, if I spin round in this chair for 20 or 30 seconds and stop moving, my eyes will keep flicking like this. So that's nystagmus. And if you've got BPPV and I drop your head over the end of the bed, your eyes will spin in a circle. And that is nystagmus. Now, some nystagmus is normal. We call it physiological nystagmus. And that's the stuff if you go and do a pirouette and spin around, your eyes jerk. And some is pathological. If you've had a stroke or you've got a problem with your brain, or you've got BPPV, for example. And the answer to how to treat it is it depends what the cause is. So there are a myriad of different causes and therefore a myriad of different treatments.
We're going to end with one final question for the panel. I know there's a few more questions that have popped up in the last few minutes, but we're going to try it. We'll perhaps get to them next time. Final question then for you both. What would you recommend as a New Year's resolution, as something to aim to do or achieve through 2023 that might help a lot of our members? Let's go with Debbie first.
Well, resolutions are completely personal and up to you. But maybe rather than resolutions, which the word is very firm and hard, you know, and that, you know, you're going to achieve them or you're not going to achieve them, maybe think about setting intentions. And intentions are much more flexible, and they're about what we want to direct our life towards and our attention towards. And they're also about being mindful. And you're less likely to sort of fail them. And so I would say, think about intentions. What's important to you in life? What are your values? And where are you wanting to go with your life? And keeping all the time in mind self-compassion. You can't pour from an empty cup. Just look after yourself.
Self-compassion, Peter, your top?
No, I can't really top that, can I? I would say one of the things that we do see that's a real problem in chronic balance disorder is deconditioning. So when you have a chronic dizziness, inevitably you're going to move less, you'll stay at home less, you stay at home more, you get off the settee and off the chair more, so your muscles get weaker, your mood gets lower, your resilience gets lower. So if you can reflect on that and just think of some strategies to get yourself more active, do more things, have more goals, get out and about a little bit more, eat maybe a little bit better and look after yourself a bit better, that's a good place to start.
Thank you so much. I know somebody, Kevin, is asking about transcribing the chat. That you can send the chat as well to people.
Everyone will get a copy, Rupal, after the meeting. In sometime next week, you'll get an email with a link to the video of this meeting and a copy of the transcript and all of Debbie's links that she's going to share with us. And I think that's it. Is it, Kelly, Rupal? We're done now. So all that remains to say is thank you so much, Professor Ray, Debbie. Again, it's just brilliant that you give so much of your time on a Saturday to help us bunch of dizzies. But we gained so much from it, and the video of this goes on to help hundreds, if not thousands of people. So brilliant of what you do. Debbie, well done in winning that Dizzy Award. There's not many of them around.
Oh, well, yes, thank you. That's kind.
And to all the members and the other award winners, thank you so much for this year. It's just great to see individual journeys, how we get to see people who can start very much on the floor and get to pick themselves up. And we all can do that. And we all need to have that hope, because we all do get to a better place. And I want you all to promise yourself to have the most brilliant Christmas you can. And as everyone's just been saying, no pressure, just enjoy it how you want to enjoy it. And we look forward to seeing you all in the new year. My only thing to say is Peter Ray's totally wrong about red wine. And that's it.
And Kevin, can I just quickly interject, because Peter and myself wouldn't be here without the fantastic work that you and your group and Kelly and Rupal do. So you are the guys who set this up. So thank you so much.
Thank you.
Peter would agree.
We love it. Honestly, the reward is to see people getting genuine help. And it's not just us, remember, it's you members talking to other members. Everyone try and join the member-to-member group. It really does help sharing with other people who understand it. But well done, everyone. Thank you so much. Have a great Christmas, and we'll see you next year. Thank you. Bye.